Everybody, welcome to this exciting webinar about colon cancer. We have an incredible panel today. My name is Manish Shah. I'm a medical oncologist here at Weill Cornell New York Hospital, and I'm joined by an incredible panel. We have Dr. Pashtun Kasi, who's an expert in colon cancer therapy, and he'll be talking to us about updates in colon cancer. We have Stephanie Roy. She is our dietitian, and she'll talk to us about important nutritional information. We have our ever-present psychiatrist, Guy Matal, who will talk to us about coping with colon cancer. And then I think you all may know Sandy Kirkostas. He is an inspiration to us all and a colon cancer survivor. I just wanted to maybe talk a little bit about colon cancer, and then I'll hand it off to Dr. Kasi. Maybe what we can do while we're waiting for more people to come in is just go around and have a brief introduction, and then we can start. So, Dr. Maytal?
Sure. Hi, everyone. I'm Guy Maytal. I am the head of psycho-oncology at Weill Cornell New York Presbyterian Hospital.
Stephanie?
Hi, everyone. I'm a registered dietitian and a certified specialist in oncology nutrition here at Weill Cornell, and I work in a few of the different centers for radiation and chemotherapy.
Terrific. Pashtun?
Hi, Pashtun Kasi, one of the medical oncologists here at Weill Cornell. Nice to be here.
He's very modest. Sandy?
Hi, I'm Sandy Kirkostas. I have stage 4 colon cancer, and I'm a survivor.
Perfect. So colon cancer is actually the most prevalent cancer of the gastrointestinal organs. And about a third of the patients are diagnosed with with disease that can be resected or can be operated on. That means 2/3 of patients, or about 100,000 patients a year, the cancer has spread past the colon. Historically, we used to focus just on chemotherapy for that population. But actually, over the last 10 years, 15 years, we've really moved to an era where we want to use all the tools in our armamentarium to try to eradicate the disease. And that includes surgery, radiation, ablation, and chemotherapy. And so, as you might imagine, it involves multiple disciplines within the cancer care continuum. That includes, a surgical oncologist, a medical oncologist, radiation oncologist. And so we really think of this as a team effort. And over the last 10 years, there's a lot of data that's come out that if you can, be part of a team effort to try to take care of your cancer, this is the time when you'll get the best benefit, the best bang for your buck. Beyond the therapeutic aspect of it, part of the team is actually, how do you cope with the cancer? How do you deal with this? It's very, very challenging. It's a tough thing. How do you address nutrition and try to maintain a healthy diet and things like that? So this is why we wanted to sort of bring our panel together to talk about colon cancer, how we manage it, and how we cope with it and deal with it from all aspects of it. So with that, I will stop and hand it over to Dr. Kasi.
As one of my colleagues put it, it's about identifying subsets of subsets. What do we mean by that? A lot of the drugs and the tools in our toolbox that Dr. Shah just mentioned, they're not necessarily meant for all types of colon cancer. It's more like lock and key. The lock has to be present in the tumor, so for the key simplistically to work. So it's what they call precision medicine or personalized medicine, which is about the right drug at the right time for the right patient. So in terms of what's also concerning, as some of you might know, more young people are dying of colon and rectal cancer. Individuals who are in their 20s, 30s, and 40s who otherwise wouldn't have met guidelines for screening. One important message is, obviously, if you meet the age for screening, do get screened. A lot of societies have moved the age from 50 to 45 years of age. But even then, we see a lot of individuals earlier than that who unfortunately then are diagnosed with advanced or metastatic or stage 4 disease. We've done some research on this as well. We're not entirely clear why that's happening. Whether it's the diet, whether it's Stephanie's going to talk more about this. Whether it's the environment, some of this is probably the genes, or a combination of all of the above. But again, what's important is even though we think of colon and rectal cancer as just one long piece of tubing or plumbing, cancers are very different in different parts of the colon, and no two cancers are alike. They're different between different individuals. Even in the same person who may have two cancers, they may not share the same traits or powers or mutations that may make them behave very differently in terms of chances for cure, treatment options, what drugs we can or cannot use, what type of surgery they might need, would they need an ostomy, things of technical nature. There's a lot of things that we're learning. And again, going back to my key message about subsets of subsets, we're identifying, these different subsets within colon cancer, rectal cancer that are very different, that may need a more personalized approach, where all this research is going into. And again, going back to what Dr. Shah was talking about, the tools in our toolbox, shown here is just a snapshot of the currently approved drugs that are available in our armamentarium to be prescribed, but some are pretty generic, shaded here in blue. Some that are more colorful, again, are more like lock and key. The lock has to be present for the key to be prescribed, and these include some of the advances for which, a Nobel Prize was awarded a few years ago. The buzzword of immunotherapy, taking the brakes off of your immune system, if that is something that is applicable. For the first time, we're hearing the word cure being used, that was seen to be a possibility a few years ago. So, it's an exciting time to be an oncologist and researcher in this field, since a lot of advances have come within the last few years. And the other thing I wanted to kind of highlight is even within the same person, the cancer can evolve over time. It's not a simple black and white blob of cells. Even because of the treatment and of all the things, especially for patients who have stage 4 or metastatic cancer, the cancer evolves over time, just like Darwin's survival of the fittest. These clones that have survived over the years may not be the same cancer anymore. So it's worthwhile checking, the mutations or the powers that your cancer may have. And sometimes that's pretty invasive. It's not safe, feasible, or possible to be doing another biopsy or surgery as patients undergoing through this, or as caregivers. This process is pretty onerous. But what's new, at least in terms of research, is we can now capture some of this information by something called liquid biopsies, which are non-invasive blood draws. The biopsy is a misnomer since no actual biopsy is being performed. Just like if somebody is pregnant, nowadays you can get a blood draw that tells you what the sex of the unborn child is as early as 8 to 10 weeks of pregnancy. If you think about it, the tumor is also a foreign being in the person. As it's shedding and multiplying the cancer cells and the cancer DNA, we can now capture this by a simple blood draw. And some of this is not necessarily future, it's already the present. Some of these are already approved and available in clinic, and we can detect DNA in the blood and see what the makeup of the person's cancer is at baseline. And also, as it mutates and evolves, we can study this over time to select the right patient treatment. And what's also important is it's having an impact at all phases of a journey of a patient with cancer. So it used to be it was something for stage 4 or metastatic cancer when the cancer had already spread, or look at response, as I showed in a few cartoons. But also what's new and exciting is some of these blood and non-invasive tests are moving to the screening level too, because I think the big question with screening is, even with the best of efforts, most states are no better than 2/3 of individuals being screened, because obviously nobody wants to drink that nasty prep and take a few days off to get their colonoscopy, which is also an issue with some of these more invasive tests. So it's good to know that some of these blood tests are also coming to become an option for some of our patients. And there's a variety of tests you can, as patients and caregivers, you should ask your oncologist about what options may be available. And I think the eventual goal is maybe for the ones who get surgery and are cured with mop-up chemo, if there's a way to find out who's cured and who's not cured. Right now we're kind of giving mop-up chemo to everybody, but with better tests we might be able to spare the toxicity to the ones who don't need it, and maybe focus our efforts on the ones who need it. And like I mentioned, in terms of screening tests, it's exciting. Every time I look around, a few months go by, some new company, some other test is now available for screening. This is just one example of a test that recently has become available and detects 50 different cancers by simple blood draw. The study was called the GRAIL study, as in the holy grail of being able to detect a cancer via blood draw. So it would also, obviously it's meant for many cancers, but advances like this would also help our patients with colon rectal cancer, because the best chance of offering cures is if we can, as they say, prevention is better than cure. If we can identify it early on, we can offer these patients the best chance at cure.
Thanks so much, Dr. Kasi. So let's talk a little bit about just to keep on the theme for multidisciplinary care and subsets of subsets. Are there patients that like who someone with metastatic colon cancer? How what's your thoughts on when to intervene with more than chemotherapy, like whether it's radiation or surgery, and maybe you could talk a little bit about the different types of radiation options.
Well, that's a great question. I think along the same lines, one important message for anybody diagnosed with colorectal cancer is it does need multidisciplinary care. We often don't necessarily cure these cancers with surgery alone or chemo alone, or sometimes radiation alone. It's multimodality, multidisciplinary, multifaceted care that offers the best chance at cure. And along those lines, one important message is, at least at some point in time, and ideally at diagnosis, these patients should be seen at an academic or tertiary care center, because the care is getting more sophisticated. And along the lines, just for example, radiation. Typically that's not meant for colon cancer, but it's meant for rectal cancer. Because statistically speaking, sometimes it's not possible to get a clean surgery because the rectum is a low-lying organ. So the radiation allows for mopping up any cancer cells that might be left behind and offering the surgeon the best chance at curing it. And to Manish's question about the options, there are short courses and long courses. A lot of our European colleagues do short courses. In the US, it's long courses. But simplistically speaking, if it's advanced or bulky cancer, the longer courses offer a better chance at curing this. So whereas the shorter courses, we often have integrated that into palliation as well, because sometimes pain can be an issue, and even if the cancer has spread, sometimes radiation can offer the best symptom quality of life improvement as quickly as possible. But again, can't reiterate this more and more, that this is a very multidisciplinary approach to a lot of GI cancers, but colorectal cancer in particular. And these decisions at any institution like ours are often made at what we call tumor boards, where all the experts gather together, not just the three interventional specialties, but also our geneticists, our nutrition colleagues, our GI colleagues, medicine. It's palliative care goes hand in hand in terms of improving symptoms and quality of life. So it's very multidisciplinary care, more now than ever before.
Yeah, and just to expand on that a little bit, as I said, historically, if the cancer has spread past the colon, we would focus on chemotherapy. But if the cancer is limited to just one additional organ, so let's say that it started in the colon and it went to the liver, then for sure you need to see a specialist as part of a multidisciplinary approach, because often we can address both the colon and the liver disease, or if it was colon and lung, the same thing. And at academic centers, we often try to address it if it's more than one organ. But for most in the community, we need to at least ask the question, even at a minimum of if it's in one other organ, we need to really think about what are the other options that we could do beyond chemotherapy. And then this is a question that sort of came up in the chat, and Pashtun, I'll ask you again. How do you manage? So there's a limitation with regard to oxaliplatin and neuropathy, and most patients who've had FOLFOX know this problem. How do you manage oxaliplatin neuropathy, and how does, and in terms of the continuum of care, what are some of the strategies that you employ?
I think this question is more relevant now than ever before, since more and more research is showing, at least for the ones who need to be, unfortunately, on ongoing control of chemo, where there's unfortunately no end to it. So it's mainly chemo to help palliate, prolong life as much as possible. Simplistically speaking, you got to pace your option. It's more about it being now a marathon, not a sprint race. So often, oxaliplatin ends up getting overused, where we know neuropathy can start becoming an issue after you cross, 4 months-ish of treatment. So it's important to kind of, de-escalate at times and revisit goals and peel off the oxaliplatin or use it for a period of time and then stop, because neuropathy can become a big issue. And back in the day, I guess when we didn't have many drugs, we had no options. But with more and more drugs coming and other options, I would say, again, every person's care is individualized, but I would, factor into what we call maintenance or de-escalating therapy, and even the question of treatment holidays. Again, not meaning that we are not going to take care of you, but maybe even taking some time off allows for the body to heal and also for somebody to recover psychosocially. So, there's provocative research that shows that even holidays, while it sometimes, if you were on some ongoing treatment, help delay the cancer from getting worse, in the long run, patients almost live the same time. So it is not wrong to bring up any issue if you're having side effects. And there are some drugs, neuropathy is a menace that is continuing to plague our patients with colorectal cancer and other cancers where drugs have neurotoxic or nerve-related damage complications. I can tell you there are dozens of negative studies, but very few positive studies that have shown improvement in neuropathy. There are some drugs that we do try that help some, but there's not yet a great solution to neuropathy once you already have it.
And I'm glad you mentioned the maintenance option. So it's been shown that if you kind of give the oxaliplatin intermittently, 3 months on, 3 months off, 3 months on, with the 5-FU infusion, that is actually as good as continuing the oxaliplatin entirely. But patients who got the intermittent oxaliplatin, their neuropathy was much better. So I think that's one of the studies that you were referring to, the Optimox study. And then the other thing is that in the adjuvant setting, where the cancer has been removed and we're giving chemotherapy with oxaliplatin we used to do it for 6 months. We've now shown that 3 months is enough. So it really begs the question whether or not all that toxicity from the oxaliplatin is really necessary. So, from that standpoint, I think communicating with your doctors about the neuropathy is very important, because there are strategies to mitigate that, whether it's a treatment holiday or holding the oxaliplatin. And then we do use drugs. In my practice, we use gabapentin or also Celexa. Celexa is an antidepressant drug, but it can also, I'm sorry, not Celexa, Cymbalta. It can also reduce the experience of neuropathy. Gabapentin is also known as Neurontin. That can also help reduce the neuropathy. And then there's a question in the chat box about icing with oxaliplatin. That's actually also emerging as a potential option. People are putting their hands and feet in ice, or even also sucking on ice chips, and that can reduce the paresthesia that happens with the oxaliplatin as well. So these are all things that can be done to help mitigate the oxaliplatin. But what I tell my patients is that it's actually not a random thing. It happens to everybody. In some people, it happens after 4 or 5 treatments, and some people it happens after 10 or 12. Well, but it happens to everybody. It's predictable, so we need to know about it. And the other thing is that the oxaliplatin-induced neuropathy, it worsens even after you stop the oxaliplatin for about a month or 6 weeks, and then it can be it starts to diminish after that. So you almost have to anticipate it. I ask about if you're having difficulty buttoning your shirt or picking up a piece of paper off a table. These are things that if you start to have that becomes a real problem. So I think at this point, what we'll do is shift gears and talk about the importance of diet and dealing with colon cancer. And I'll introduce Stephanie Roy.
Okay, so I thought today I would talk about a couple of the most common topics that I do hear questions about from my patients with colorectal cancer. So we'll talk about a couple of common nutrition myths and importance about them. The main goals that I want to cover today are looking at the relationship between eating sugar and cancer, looking at the relationship between eating meat and cancer, and specifically colon cancer, and also understand some of the benefits and risks of vitamin supplements. So myth number one that I want to talk about is the idea that sugar feeds cancer, and that we have to be afraid of eating foods that contain sugar when we're going through cancer treatment. So why does this come up so often, sugar and cancer? Well, carbohydrates in our foods are made up of sugars and starches. So your body will break down carbohydrates into glucose, and glucose is an essential fuel for our body cells, and they help give our body cells energy. Now, both normal cells and cancer cells do use glucose for energy, so that's where this relationship comes up. And I think there's a lot of information in the news and the internet that gets misconstrued. So does eating sugar cause cancer? And the short answer to that is no, there's not a direct relationship or research showing that. Glucose is part of carbohydrates, but complex carbohydrates that we eat also contain essential nutrients that our bodies need, such as fiber, vitamins, and minerals. Now, added sugars are those that are found more in processed foods, such as sodas, concentrated sweets like desserts, or refined carbohydrates. And these are the sources of sugars that are not essential for our body. So eating a diet high in added sugars might contribute to weight gain, and being overweight or obese has been shown to be a risk factor for some cancers, including colorectal cancer, but research hasn't shown a direct relationship between eating foods that contain sugar and cancer. Now, that being said, we do still want to limit these added sugars for overall health. So while we don't have to fear these foods, we do want to try to aim to get less foods with added sugars. The most common sources would be sweetened beverages like soda, that's the leading source in this country, and also things like desserts and sweet snacks we want to save more for an occasion or keep our portions smaller. Now, the American Heart Association's recommendation is up here, about 9 teaspoons at most for men and 6 teaspoons for women. In grams, that would be about 36 grams for men and 25 grams for women. Now, as far as carbohydrates go, we generally want to try to choose carbohydrates that are high in fiber, such as vegetables, beans, lentils, fruits, and whole grains. Especially whole grains are associated with lower risk for colorectal cancer, so they're great sources of carbohydrates and energy for our bodies. And we want to try when we can to limit serving sizes of refined foods that are made more from white flours, such as white pasta, bread, and bagels. Now, there is an exception to this I want to mention, because there are certain points in treatment where you may need to follow a low fiber diet, such as after surgery, or if you're having certain digestive side effects of treatments like chemotherapy. So in those cases, you would want to include more of the refined carbohydrates. Now, the second topic I want to go over today is the idea that you can't eat meat after a cancer diagnosis. And this is myth number 2. So does meat cause colon cancer? So there are different categories of meat. We define it as the animal muscle that we eat as food. There's poultry, which includes chicken, turkey, and then we have our red meats, beef, pork, veal, lamb, as well as the processed meats, which are those that are cured. They add lots of salt and preservatives, things like bacon, cold cuts, and sausage. Now, red meats and processed meats in particular are associated with a higher risk for colorectal cancer, especially the processed meats in particular. Now, there's different thoughts to why this might be, though it's not known, but when cooked at high temperature, meats can produce cancer-causing compounds, and eating lots of red meats may also increase low-grade inflammation. Now, the American Institute for Cancer Research has recommendations out, and we don't need to completely avoid meat, even red meats, after cancer diagnosis. So the current recommendation is to limit red meat consumption to no more than 12 to 18 ounces per week. And this is roughly about 3 servings that are the size of a deck of cards. When possible, try to choose unprocessed meats. So it would be better to have eating fresh roasted meats over something like a cold cut in a sandwich. When cooking meats at high temperature, you can actually marinate them with oil and fresh herbs for about 30 minutes beforehand. And that was shown to decrease the formation of cancer-causing compounds when grilling meats by up to 90%. So that's a great tip going into grilling season. And then you can try to replace half of the meat in a recipe with chopped or grated vegetables, such as pudding mushrooms in a meatball recipe. Now, protein is a very important nutrient, especially for anyone undergoing any sort of cancer treatment. So we really want to maximize protein and not restrict too many foods. There are tips that you can do to maximize protein while also helping to incorporate more of these healthy foods. So you can include omega-3 rich fish at least 2 times per week. Things like salmon, tuna, sardines are great sources of these anti-inflammatory fats. If you tolerate them, you can add plant proteins such as tofu, beans, and lentils for an additional source. When eating meat-based proteins, you can follow the American Institute for Cancer Research's plate, which is shown here. They call it the New American Plate. And the idea is that you're making whole grains, fruits, vegetables, plant foods, 2/3 of your plate, and keeping that animal protein portion a bit smaller. And the benefit of these foods is they're not only associated with lowering risk for colorectal cancer, but they may also help with improving survival after diagnosis. Now, during treatment, again, it's important to avoid food restrictions, especially if you have any side effects like low appetite or digestive issues that make it hard to tolerate fiber. So we want to keep the emphasis on adequate protein and nutrients from various sources so that you don't become malnourished during the treatment. Now, the last topic I get asked about a lot is, do we need supplements to be healthy? Now, this is a myth. Dietary supplements come in a lot of different forms. There's so many marketed out there, it might feel overwhelming, but the US Food and Drug Administration doesn't determine whether dietary supplement claims are effective before they're marketed. There are potential risks also with dietary supplements. There are lots of calls made to US poison control centers every year, and taking really high doses may even have harmful effects. Several examples listed here, such as too much vitamin A can cause liver damage, reduce bone strength, and headaches, and using too much zinc long-term can also cause copper deficiency. Now, there can also be drug interactions with certain supplements. So, for example, St. John's wort can reduce effectiveness of medications such as antidepressants, immunosuppressants, and even some cancer treatments. And antioxidant supplements may also reduce the effectiveness of some treatments such as radiation. So definitely important before starting any supplements to talk to your dietitian, talk to your doctors before starting these. That being said, there are some potential benefits, and there's a place for dietary supplements in some health conditions. So calcium and vitamin D are important for keeping bone strong and reducing bone loss. You may need iron or B12 supplements if your level tested shows deficiency. So in some cases, we do want to include supplements. Now, I get asked about specific supplements, so I'll try to just give a brief overview of a couple that I hear questions often. One is vitamin C, helps maintain healthy immune function, helps wound healing. And some studies do show that getting a lot of vitamin C from foods, which is mainly found in fruits and vegetables, might reduce risk of certain cancers. But most large trials that studied vitamin C supplements didn't show that they did prevent cancer. Clinical studies show that oral vitamin C is not effective, and that may be due to limited absorption. And high-dose IV vitamin C is still under investigation as part of a cancer treatment. So important, like anything, if you're thinking about taking a supplement, to first check with your oncologist before starting these. And another one I get asked about often is turmeric. So this supplement, and you also may hear of one of the active components, curcumin, as a supplement. It helps to prevent inflammation, neutralize molecules that can damage our cells, such as free radicals. Can have also some bad side effects at high doses. There have been some case reports of liver injury and even neutropenia or low blood counts due to this supplement. There is a trial underway to evaluate the safety and effectiveness of using turmeric in patients with metastatic disease. The current research we have is pretty mixed as far as results. Also important, it can interfere, possibly reduce the effectiveness of some chemotherapies, drugs, immunosuppressants. But the spice form of turmeric is a great flavoring with some anti-inflammatory benefits, and that's generally safe to use in cooking. Now, the last supplement I wanted to highlight is vitamin D. It's important for cell growth, immune function. It helps our bodies to absorb calcium. It's mainly synthesized on our skin with exposure to sunlight. We actually don't get that much of this vitamin from our foods, but it is found in fatty foods and fortified in certain foods like dairy. Deficiency of vitamin D or a low level of vitamin D is associated with an increased risk for colorectal cancer. And some studies suggest that adequate vitamin D levels are associated with better overall survival of colon cancer patients. It's also being studied alongside certain chemotherapy regimens and trials currently. This is a vitamin actually that I find a lot of times people do need to supplement, but the best thing to do is check a level so that we know if your level is adequate or deficient, and then we can recommend the right dose for you and monitor your level over time. And that's easy to add on, so you can always ask your doctor to check. So in summary, for supplements, evidence is limited that they can prevent or treat cancer, but we do have a lot of research going on studying these. Specific components of supplements might interfere with certain cancer treatments, so we have to be careful about taking some of these. Supplements do have a role with deficiency, and also a lot of the supplements marketed to prevent, treat, or cure cancer are not regulated and can be potentially dangerous. Now, if you're not sure, you can always ask your doctor for a referral to speak with a dietitian, ideally someone who's trained in oncology, and we can base nutrition advice for your individual needs and medical history and preferences. And that's all I have. So I'm going to pass it back over to Dr. Shah.
Can you talk to us about the ketogenic diet or intermittent fasting and like pros and cons and things like that?
But just to mention those two diets, the keto diet is, there's more and more studies that are coming out about it. It's basically a very high fat diet, very low in carbohydrate, and also the classic keto diet is very low in protein as well. So the main study showing benefit for ketogenic diet is in brain tumors. We don't have much evidence to support it in other disease states at this time. It also can be a little bit difficult to tolerate. Such a high fat diet, especially for patients undergoing treatment, can be very difficult. Also people with low appetite. So in those cases, I don't usually recommend such a restrictive diet because we have lots of research showing that malnutrition is associated with worse outcomes. So I think we want to try to keep the diet less restricted if possible. Intermittent fasting, there's starting to be a little bit more research coming up on this topic, but typically we don't want to be restricting too much. You might have issues with appetite or trouble tolerating certain foods. So keeping the window short of when you're able to eat and maximize those nutrients could lead to things like muscle loss, malnutrition. So again, if you have questions, it's good to consult with someone before starting any sort of restrictive diet, and we can help clarify, why it may or may not be a great idea to try.
So, Dr. Maytal, thanks so much.
We're going to talk about stress during cancer and what to do about it. But one of the first things we have to get on the same page is, what is stress? See, if I ask you, is stress a bad thing? Mostly you'd say yes. We want to have less stress, want to reduce the stress in our lives. Everything online and on TV is how to have less stress, more stress bad, less stress good, right? But it's not necessarily the case, because stress is part of being a human being. Stress is certainly part of having a major medical illness and dealing with all of the things you have to deal with ongoingly in your life around it. So the question isn't how to get rid of stress. It's how to deal with it when it inevitably arrives and frequently arises. So let's talk about what it is. Stress is actually a scientific term coined about 100 years ago to talk about a physiologic response that the body has to challenges and to change. And it's developed over time to be much more broad and as an environmental conditions that require some behavioral adjustments. It actually has two components. You know, the one, it's called distress, meaning negative stress, where there's a negative response to a changing environmental condition. But there's also something called eustress or good stress, which is a positive response to something new in the environment. Something new, of course, includes a new symptom, a new diagnosis, changes in behavior that you have to engage in once you start treatment. All of those are changes. You see, it's an essential aspect of life. And remember, too little stress, you're not going to function well. Too much stress, you're not going to function well. So how do you find and stay in that middle zone more often than not? One of the things to underline is having a lot of kindness for yourself to mess it up. I think one of the challenges people have when they go through colon cancer is if I do something wrong, it will hurt me physically in some way. There's a big broad highway of things that you can do. You're going to feel bad and then you'll feel better and you'll like what's going on or you won't. Having a lot of space for whatever reactions are arising is really critical for you to move the needle back when it inevitably goes to one extreme or another. See, part of the challenge for us as adults is cancer isn't just a set of illnesses. It immediately points to death, or at least to one's mortality. You know, I say cancer, most people hear death. And at least uncertainty, you know, things I often hear people say, my life wasn't supposed to go this way. And it opens up a lot of questions of prognosis, of the side effects of which treatment, can I go to work, reproductive issues, intimacy concerns, can I maintain my social roles, financial uncertainty, and on and on and on. And so even if you're not one of the people for whom cancer is associated with death, it means an unexpected, abrupt change in all of these areas. There are physical changes, there's psychological changes, there are social changes that are getting, thankfully, more and more attention, especially the financial burdens of cancer and cancer treatment. And then, of course, there are the existential questions, the kind of the big questions of life. And all of these are happening at the same time in various degrees, depending on where you are in life and what you're currently dealing with. So it's kind of like, you know, these two diagnoses of cancer is like, here you are, you're flying the plane with your buddy, and you turn to him and say, what's a mountain goat doing way up here in a cloud bank? You thought you were going one way, but here comes that mountain. And part of the challenge of dealing with stress is that we evolved the acute stress response back before civilization. It was essential to survive at a time when there are many ongoing, imminent physical threats. Some predator or some other person's coming to kill you. But when it's not happening, there's no stress. So it spikes up and then comes down quickly when the stressor is gone, because the stressors were always quick. But in modern life, the stressors are much more chronic. And they're often physiologic or interpersonal, rather than a lion coming at you in the middle of the savannah. So the stress response persists, and the body reacts as though it was still facing an imminent physical and even existential threat over and over and over again. So when we say stressor, we're talking about anything that throws your body out of balance, and the body attempts to survive by changing its hormones, by turning on the nervous system, by additional physiologic changes, and we attempt to survive by taking on new behaviors or not. See, the psychological stressor of having a medical illness of any sort, and certainly one as difficult as colon cancer, is in and of itself a psychological stressor. Some people find it, I'm gonna find some power in this. Some people want to ignore it. Some people do not like to see themselves as a patient. Some people get frustrated with it. There are a lot of different ways that it impacts people psychologically. And at one end is this existential threat. Because there are moments when you think, is this going to kill me? Am I going to die? There are also moments when there are worries about physical safety, like basic needs. Can I afford my life? Food, shelter, employment, finances, childcare. Sometimes we get ashamed by that. Sometimes we avoid phone calls. We also miss appointments because you're dealing with immediate needs. Maybe there's a child in your life who needs attention and you have to choose, do I go in for a session of chemotherapy or do I have to attend to my child's needs, and how do I manage that? Some people go bankrupt. You know, the term financial toxicity, you may have heard, is not one I'm fond of because it implies like it's some inevitable outcome. Like, you know, chemotherapy or other pharmacologic treatments have an inevitable toxicities that go along with them. Calling it financial toxicity implies like we didn't make up the system where people go into financial distress. So, but that is a reality for many, many people, especially when they're dealing with cancer. And yet, here's the and yet. So all that's kind of like the awful negative side of it. There is that positive side. As the great philosopher Taylor Swift said, stress is the critical ingredient to any success. So how do you balance the stress that shows up around all of these worries and concerns and physiologic changes with the need to have some degree of stress? This positive stress, you see, sometimes it motivates us. It focuses us. We see that we're dealing with something within our capacities. It even can feel exciting and it improves our performance. See, this is Emily Harrington. She's a free climber. This is not photoshopped. She's about 3/4 of a mile up a wall with no ropes in Yellowstone National Park. This is good stress for her. She is motivated. She's moving her way up the wall. She's not panicking, but she's not exactly lounging in front of the TV either. Here you have Dr. Fauci and Walensky, two of the leading doctors during the COVID pandemic. They're about to testify in front of a congressional committee. They're not lounging either, but they're kind of revved up, ready to go. It's that kind of stress that's like, I've got this. Yeah, I'm a little nervous, but I'm going to take it on. And then there's a distress. So how do you move between them? Well, here's one of the critical aspects. And this really is what you have a say over, because we rarely have a say over the circumstances that we're dealing with. Certainly not when you're dealing with the consequences of colon cancer, its treatment, and what that all entails. But you do have a say over the context, because our responses are filtered through our interpretation of events. See, you can interpret anything as either a challenge or a threat. Once it's a threat, it becomes distress. Once it's a challenge, it's how do I get through this and what do I need to do to get myself some help? In other words, is it going to be, it shouldn't be this way? Or is it going to be, well, this is the way it is right now. I wish it wasn't. Now what? See, the issue isn't the amount of stress, because we really don't have a say, but how you cope with it. And then there's a word that's used, it's called resilience. This is the deer obviously finding a creative way to cope with the hunter. Resilience is the ability to recover quickly from change, from misfortune, from illness. And that doesn't mean recover like being cured. It means dealing with the change that happens. And one of the most difficult aspects of going through cancer care is that the speed of change is hard to imagine for people who aren't dealing with cancer. one test result, and then there's a new symptom, and then there's a new side effect, and then things are good for a while, but then there's another issue that comes up just when you thought it was safe to go back in the water. Change after change after change. And the more you can develop your resilience, the better you'll feel. And that doesn't mean that if you feel bad, there's anything wrong, right? So what can you do? You can reduce, I should really call it distress, and enhance resilience. So here's a couple of ways to enhance resilience. They live in a few categories. Self-care is really important. That includes learning stress reduction techniques for when you're feeling like life is too much to bear. Connecting with people. Setting appropriate boundaries. Learning to use that really powerful, difficult word, no. Finding ways to communicate what's going on with you to other people, and then just really practicing some hope. Taking care of yourself literally means taking care of yourself. People need sufficient sleep. People need regular meals. People need to move their bodies. People need sunlight and frequent watering. And I invite you not to get hung up on some specific numbers here. One of the things people often come to me worried about is I'm sleeping too little. There's something wrong. I'm not getting 8 hours. 8 hours is silly. You get sufficient sleep as best as you can. And then try to do what you enjoy. And if you can't, because of whatever reason, be kind to yourself. And bear in mind that human beings get sad and excited. We get angry and happy and tired. All of it's human. Angry is no better than happy. And it's no worse than happy. It's what you're experiencing. And as human beings, we are designed to be social, connecting with others, to be cared for and to take care of. And one of the challenges for many people when they're going through cancer is the worry that they're being a burden on their loved one. Well, maybe you are, but that's how they get to show their love for you. See, if you're worried about being a burden and you're taking yourself away emotionally or interpersonally or not asking for things, either you're going to suffer physically or in some way because you're not getting what you need, or you're actually going to be distanced from the people around you. They know you're going through a hard time. And by the way, they have no idea what it's like for you. None. And I often remind people, it's not their job to know, it's not their job to understand, it's their job to love you and support you. And lastly, there are these stress reduction techniques that you can learn in little chunks. Little chunks. You just got to find something that calls to you. Some of you may have practices of meditation or other relaxation modalities. Some of you may not. Any sort of body movement helps. And then when I say exercise, it could be as simple as a walk around the neighborhood. Meditation, yeah, for some people that sounds like a woo thing. It could be as simple as saying a prayer, or it could be as simple as learning a meditation technique. There are so many videos on YouTube around guided relaxation, meditative walks, 5-10 minutes. And for some people, they are still physically well enough to be more active than things like yoga. There's even something called laughing yoga where people get together and laugh. It's forced at the beginning, but the nature of laughter is that once you start, you kind of get into it and you find yourself laughing for no reason. And finally, connecting with people. One of the things that really helps resilience is being with people in your life, sharing what's going on with you, the good stuff, the bad, in some meaningful and non-judgmental way. It may be with your family, it may be with your friends. That may be too challenging. Maybe you go to a group of people who are experiencing something similar, like a support group. Maybe you find a therapist to talk to, in person, online, whatever works for you. So in summary, just to remind you that the thing you have a say over is shouldn't be versus it is this way and I wish it wasn't. The brain interprets situations as stressful or not based on the context that you bring. And then you have a choice about how do I modify things just a little bit to move me maybe down that scale from severe distress to maybe that more I've got this portion of that graph. And finally, find what works for you and be kind for yourself as you struggle through it. So thank you for your listening.
Are there, you know, that one question that comes up, and I think there's in the chat as well, is that a lot of people are looking for support in some fashion or another. Um, I know that there are many groups that are available, Michael's Mission and other things. Can you speak to that a little bit?
Sure. I think that we really do need to be better at having some sort of central clearinghouse for these kind of supports. One of the things that you have to look for yourself is sometimes people think that they need to be with someone who's just like them. It may not be the case. Maybe you find people who are like you in age and going through an illness rather than having the same diagnosis. Kind of to see what works for you. The American Cancer Society has a great clearinghouse for groups that are available online, and that the world of Zoom during the pandemic has really opened up the whole nation to anyone, anywhere for finding a support group. Those are the best way to do that. But building your own support groups is also really useful. Like having a team around you of people who you like that can kind of pick you up when you're not doing so well is really helpful.
No, I think you're absolutely. Sandy, did you want to comment on that?
Everything Dr. Patel said was on the money in my journey. Every single thing he said. I had the support group. I got depressed. I had stress. Again, I had stage 4 colon cancer that metastasized to my liver, my bladder, my stomach, back to my bladder, to my liver now. I started chemotherapy yesterday. And excuse me if I have hiccups because the 5FU gives me hiccups. So if I'm talking and I have hiccups, I apologize. But the support group is really, really powerful because when I got diagnosed, I did not know anything about cancer. The first thing you think of is death. And my journey was very hard in the beginning. And I don't know how I got through it, but I had so many questions and answers. And my biggest thing was finding Dr. Shah. I went to a few doctors that gave me no hope. They couldn't even help me. No surgery, unoperable. I've had 14 surgeries in 8 years. I had a colon resection, 2 liver resections, 2 bladder resections, a few ablations in the liver, hernia surgery, on and on. So I went through a lot. And anything that anybody is dealing with, I've dealt with it already. And I started my Facebook page, Cancer with Sandy, just to help a couple people, not realizing that we have almost 700 people on the group. And I get messages from South Africa, from Australia, from London, from all over Europe and all over the United States. And it gives me so much pleasure to help people and give them hope because Dr. Shah gave me hope. And I realized when Dr. Shah gave me that hope, I let the science and Dr. Shah's team, because we built a team around me, and let them do their thing. And I decided to myself that I'm just going to live. I juice regularly, or fresh fruits and vegetables daily. I, try to watch what I eat. And of course, sometimes you go off it because you're like, okay, I'm fine. And then things happen again and things reoccur. So you're trying to just be a normal person, but when you have stage 4 colon cancer that metastasized all over you, you really have to stay on course. And the biggest thing for me was a support group because number one, you're scared. You don't know what's going to happen. You always have the thing in the back of your mind of death. It's been 8 years now, and I live a normal life. Regardless of my cancer, my treatments, and what I've been dealing with, I live. And the biggest part was my support group. I tried to relieve the stress, and I tackled, okay, what's giving me the stress besides my cancer? It was financially, It was the stress in my life. I got rid of all that. Did it take me a year or so? Yes, but I got rid of it, and I stuck to helping people, and I felt like I made this negative cancer in my life a positive because I felt like, okay, maybe this was given to me because I need to help people. And I made that the biggest part of my life is helping people. And my support group, Cancer with Sandy on Facebook, I love it. And I love helping people. And I watch people interact with each other because everybody has their own journey. And my journey is my journey. And I'm here just to help people and educate people. And please get colonoscopies at 45 if you can, or younger if you can. Because if I got a colonoscopy before 47, I probably would have saved a lot of headaches that I'm going through now. But again, you have to find a doctor that you're comfortable with, and they put a team around you and live your life. And that, and I found Dr. Shah and his team, and I'm blessed. And now I want to return that with helping people and educating people on my story, because my story is different than anybody else's.
I think that you're really an inspiration because through your journey, you've had a lot of ups and downs, and you've stayed positive throughout. And I think that's one thing that I don't know if we've talked about it, but I often talk about that with my patients. That it is a journey, and there are lots of ups and downs, and we try not to ride the Loch Ness monster like the huge big roller coaster. We want it to be a kiddie ride. I mean, and maybe you could talk about that a little bit.
Well, that's where the part is like, listen, you don't have a choice. And that was the biggest thing that I got over all these hurdles with you, Dr. Shah, because you've been on my journey the whole ride. And we've had ups and downs, and we had real ups and real downs. And my thing was, I don't have a choice. So my choice was to just live and let you handle the medicine and the techniques and the chemotherapies and the surgeries, and you get very depressed. And I think I'm strong enough to snap out of it. But like, we just recently, a week or so ago, me and Dr. Shah, that my cancer came back in my stomach and in my liver. So I started chemotherapy. Now, when I read the report, like, I'm a little bit educated now, so I read the report before Dr. Shah because I get them on the portal. But when I read it, I just got so depressed. And then Dr. Shah texted me that he got the reports. I said, I read it. We'll talk when I come in Tuesday. The weekend is the time for me to be depressed. But then Tuesday came, and I'm back to normal, and I'm working today, and I did my chemotherapy yesterday, and you have to keep living. I don't have a choice. So you have two choices: to lay down and be depressed, or get up and live. And I think the psychological part of the whole journey of my ups and downs is my mental state. I just try to block it out as much as possible and live my everyday life. Travel, work, whatever it is. And when it's time to see Dr. Shah, I see Dr. Shah. Every 2 weeks we do the chemotherapy, and we'll hopefully get through this down point in my journey right now.
One of the questions that came up earlier on was about diet and someone who has an ostomy. Stephanie, you want to talk about that?
Yeah, definitely. So this is one of those times after an ileostomy or really most intestinal surgeries that following a low fiber diet might be necessary. Now that being said, people who have ostomies, maybe even permanent ostomies, doesn't mean you have to avoid fiber altogether, but it is important to note that an ileostomy is smaller. So we have a higher risk for obstruction, and we want to make sure that adding fiber is not going to, cause too many changes to output or put you at risk for dehydration. So it's pretty individual, but most people with ileostomies can tolerate certain types of fibers. And there's, more digestible fibers, less digestible fibers. So it's a good conversation to have with your dietitian because everyone's a little bit individual, and most can tolerate and get back to, I have a lot of people who normally ate a high fiber diet and they miss those foods, so we can usually find ways to incorporate them, even if it's in a different form than before.
in more of a general sense, Dr. Kasi, what are, like, in the adjuvant setting, what are your thoughts between single agent 5-FU versus a combination, and then the role of capecitabine?
I think it's on a broader stroke. It used to be that we had just one chemotherapy, the 5-FU being the IV part and the capecitabine being the pill part, till oxaliplatin or the platinum chemotherapy came along. In general, if somebody is otherwise fit and healthy, for somebody with any kind of stage 3 cancer, often it's some sort of a doublet therapy to offer the best chance of cure. The platinum therapy does add a few more people that we cure with cancer. Again, if we had a crystal ball to know who needs chemotherapy and who needs single and double, I think our job would be a lot easier. However, in the absence of a big medical problem or a huge issue, would lean towards some sort of doublet therapy. And also, like Dr. Shah earlier mentioned, we've learned over the years that 3 months may be as good as 6 months. So a lot of the chronic issues arise when people get more than 3 months of chemotherapy, and for early stage 3 cancer, we can get away with 3 months. So I would suggest, to be open to those discussions.
Just to add to that, I think the sometimes people forget that the most of the benefit by far is from the 5-FU, the fluoropyrimidine. So from a toxicity standpoint, the oxaliplatin adds most of the toxicity and the least benefit. So as you're discussing with your oncologist, the options to sort of think about one or the other, these are things to consider. Let's look at the questions in the chat box again. How about this? What are any benefits to low dose aspirin in the adjuvant setting? Stephanie, do you know that, or can you talk to that, or maybe Pashtun?
So one thing for sure that's intriguing about aspirin in general, I think there are a lot of positive studies both in the treatment as well as preventative. I think in the prevention setting, it is showing, and it's part of a lot of treatment in terms of prevention for Lynch syndrome or the hereditary cancer syndromes. There's definitely a role, and along the same lines, we're doing more trials of newer drugs and agents to help prevent new cancers from forming. So I would say overall the results are positive.
Yeah, I think that, and also from the adjuvant setting, there's actual not randomized, epidemiology data that suggests that tree nuts, 2 ounces twice a week, help reduce the risk of colon cancer as well. And then I think, let's see, we haven't touched on this thing, exercise. Any specific recommendations in terms of exercise or staying active? And so what are your thoughts on that? Anyone can answer.
I think it's there's increasing actual interventional studies to show that exercise, even after somebody is cured with cancer, can help with overall survival. Even on treatment, beyond treatment, to help fight cancer-related fatigue, chemo fatigue, there are not many agents, but activity of any sort is of value. I've been pleasantly surprised to note that more and more of these supportive care interventions that are revolving around nutrition and activity are being actually studied in an actual trial setting. So I don't think there's any doubt about the benefit, but then with these actual studies, we can actually quantify the true benefit.
And I think too, there's been some good studies showing, increased quality of life for patients undergoing chemo treatments and after diagnosis. So not only do you see more benefit in things like survival, but actually how patients are feeling in their day-to-day lives, which is so important. So I talk about exercise with almost all my patients. Definitely important for anyone who's received a diagnosis of cancer.
Steffi, thanks so much. I think that it is important. And in fact, it was also shown in an epidemiology study that people who exercise also have a better outcome, and whether that's because of improvements in the immune system or overall mental well-being, all those things are very, very helpful. We have a few minutes left. I just wanted to highlight one thing that we talked a lot about the multidisciplinary care involved for taking care of patients with colon cancer. It truly is. It really does take a team or a community to give our patients the best options. And I think the other thing Dr. Kasi mentioned about at least getting an opinion at an academic center. One of the advantages of that is that there may be novel clinical trials that are testing new hypotheses, new strategies to treat cancer. One thing, there's a lot of questions about vitamins and things like that. So we actually have two trials ongoing now. One is a national study looking at the role of vitamin D with chemotherapy in colon cancer, and the other study is a study examining the role of vitamin C and how that might be able to help radiation therapy for patients with liver metastases. So these are there are lots of things going on with regard to research and advancing the care, and I think that's one of the benefits of that. Let's see, looking at the questions. So this is a question for Stephanie. Why would foods high in fiber be more likely to cause a problem with patients with an ileostomy versus one without?
Yeah, so as far as for ileostomy, just because compared to a colostomy or compared to someone without an ostomy altogether, it just is a smaller lumen. So, you're at more risk, especially right after the surgery, if you're not chewing your foods well, for foods that are in larger chunks to potentially cause a blockage. But that being said, I've had patients with permanent ostomies who've had them for years and are chewing their foods well, hydrating well, and they do tolerate a fairly standard diet with good amounts of fiber. But after surgery, it's important while everything's healing up. Some people do have an issue with a higher output from their ostomy, again, also due to the physiological differences of the ileum versus the colon. So all these things that we have to take into account when deciding what types of fiber, how much fiber, and it can be very individual from person to person. But great question.
Okay, so I think we're officially out of time. There are lots of questions, and I wanted to thank everyone for their participation. And this for me was really, really quite inspirational. And maybe we'll hand it off to Sandy for the last word.
I just, as much as it was inspiration for all of you, it was an inspiration for me because every day I learn. And if anybody needs any kind of support, please go to my group Facebook page, Cancer with Sandy. I'm here to help, and everybody on the site helps each other. And Dr. Shah, I just want to say I love you, and I'm just so pleased that I found you.
Thank you so much. Thank you so much. So thanks everybody for joining our webinar.